Hello, hello everyone. I'm back. This time I have a new video about peripheral vascular disorders. So let's get started. The first disease that we're going to talk about is peripheral artery disease. And we commonly call it PAD or abbreviated as PAD. This disease is basically thickening and narrowing of your peripheral arteries due to arteriosclerosis, or that plaque, that buildup of fatty deposits that get hard. It is about 8.5 million people that suffer from this disease in the United States. And people that are at high risk for PAD are smoking, diabetes, hypertension individuals, high cholesterol, people above the age of 50, African Americans, sedentary life, high levels of hormones, stress in women, in African Americans. I said that already. So pretty much a little bit of the patho is just a normal artery is unblocked, is open, blood flow passes through. But when arteriosclerosis or that plaque starts building up, it starts narrowing the lumen, and that leads to blood clots that can attach the plaque or just completely absence of blood flow. So people that suffer from these disease can manifest different symptoms or signs and symptoms, and they're pretty distinct. So I try to kind of highlight them here in a different color, so that way, whenever we talked about peripheral venous disease or the venous portion of it, you can differentiate them. So they have this pain with activity and exercise that gets better whenever they rest their legs, and it's called intermittent claudication. That's what that pain with activity is called. They can suffer from numbness, burning, and decreased sensation. Usually their pulses are absent or very decreased. They're not going to be your beautiful +2 bounding. They have this skin that is thin, is shiny, and hairless. And their nails, excuse me, become thick. Now, when the leg is elevated because of a decrease of blood flow, because at elevating the leg, they get paleness or pallor. Now, if they put their legs down in a dependent position, they get this rubber color that it's like red dark. They're because the skin becomes thin, they are a higher risk for developing ulcers or wounds. Now, we can diagnose PAD in just a physical examination and history of the patient, but we can do different diagnoses to kind of determine the extent of the damage. And one that we commonly do is the duplex ultrasound or Doppler ultrasound. Now, yes, they can get oximetry and they can get angiograms and whatnot, but an ultrasound can tell you if the artery is clogged or the degree, the extent of the damage, and it's not as expensive. Now, some people do require other ones. And it kind of looks like this. This is what the duplex ultrasound of the extremities look like. The color just kind of highlights, in that way you can tell where the blockage is. Now, they can develop many complications from the absence or the decrease of blood flow, and one that it's common is ulcers. Also with the thin skin, it starts breaking, and then they develop infections, which can lead to gangrene and amputation. Think about an individual that is diabetic, has perhaps bad lifestyle, and then they also have peripheral artery disease. Diabetes doesn't allow wounds to heal correctly because of the elevated glucose levels, and then on top of it you have less blood flow, it's a recipe for disaster. And so a lot of people end up with amputations. Now, they do suffer from this something called critical limb ischemia, which basically means severe ischemic rest pain. So when they're at rest, they have this pain due to the ischemia that lasts more than 2 weeks. We treat it in different ways. Really, the goal of the treatment is to reduce the risk factors for cardiovascular disease, such as, you know, lower your blood pressure or prevent hypertension. Do a diet that is low in sodium or salt and low in cholesterol. Or bad fats, avoid smoking, control your sugars, or prevent diabetes. Exercise. So we want to exercise for at least 30 to 45 minutes, at least 3 times a day, like walking, biking, etc. And then avoid alcohol. We do educate them on a meticulous foot and leg care, which involves inspecting, cleaning, and lubricating the leg. If the individual cannot see for any reason, or perhaps they have mobility issues where they cannot reach their feet to inspect them, you should tell them that someone else should look at them daily. Also, we lubricate the skin to prevent any cracking from the skin being very thin, and kind of they can dry out as well. Treat any cuts rapidly and any infections as well. And wear always shoes, closed-toe shoes, to prevent any cuts or any wounds to the feet. They should also wear support hoses like TED hoses and rest. There is a medication therapy, pharmacological therapy that involves antiplatelet agents and cholesterol reducers. So the antiplatelet agents that we focus on is two medications. Aspirin, 81 milligrams. We call it a baby aspirin. And so pretty much what they do, these antiplatelet agents, they prevent platelets from sticking and forming a clot, basically. Also, the other one is clopidogrel, commonly known as Plavix. And again, it's an antiplatelet, so it prevents platelets from aggregating and sticking to each other. So the risk of bleeding here increases, and also because it lowers platelets or inhibits platelets, you want to monitor platelet level. Aspirin in particular can cause GI ulcers and further bleeding, so be careful in also educating the patient with ulcers, making sure they take it with a full glass of water. And if they are taking any of these medications, they should instruct their doctor before they get any procedures done. The cholesterol reducer medications have different classes. So the first one is HMG-CA reductase inhibitors. They end in statin, simvastatin. These cause liver enzymes to go up. They also cause muscle pain and weakness. So they should be monitored for something called rhabdomyolysis, which is the breakdown of the muscle, and it causes pain and your creatine kinase levels to go up. The next class is fibric acid derivative. They kind of have fibrate or fiber in the word, so you should be able to identify it. So they also have liver enzymes elevated and can cause GI issues like nausea and diarrhea. We can restore blood flow with minimally invasive procedures. One that we commonly talk is percutaneous transluminant angioplasty, or TPA. Basically, the doctor goes through one of your femoral arteries with a balloon tip catheter, and then that's inflating, kind of pushing that plaque against the walls of the artery and restoring the blood flow. They sometimes put a stent that the stent has antiplatelet drugs as well to prevent clot in that artery. After the procedure, you should educate the patient on what's going to happen. But let's talk about what happens before the procedure. It is an invasive procedure, although it is minimally invasive, but they need to be talked about the procedure, sign consents, be NPO for 6 to 12 hours. They run blood tests such as a CBC to look at the level of hemoglobin and red blood cells and all that. Also, they look at their renal function because they insert, they push dye to kind of paint the artery, and that's filtered through the kidney and it's a little harsh on the kidney, as well as coagulation studies. They monitor your heart rhythm with an EKG, and they take your vital signs every 15 minutes after the procedure. Because you are puncturing an artery and you're messing with the artery itself, very important neurovascular checks every 15 minutes when they get out of the procedure, and they're looking for the pulses or the extremity distal to where your puncture site is. So pulses, color, sensation, movement, and pain. The insertion side, it's monitored for bleeding and hematoma. Pressure is put on the insertion side to avoid bleeding and for the blood to coagulate basically there. And you also instruct the patient to do not bend the leg except during exercises. In this also way, there's a procedure called arthroectomy. Basically, they put the catheter, but it has this stool that kind of turns and cuts and shaves off the plaque. Other procedures that can happen is a femoral popliteal bypass graft, where sometimes arteries cannot be accessed or they cannot be fixed, so to speak. So they bypass it with a graft from the part that has blood flow to the other part that has blood flow, and bypassing the block. And finally, another procedure that can happen is they open the artery and take out the plaque. If you do develop an ulcer, or what to do for when you have an ulcer, you want to keep your legs dependent because, again, blood flow, it's limited. So if you elevate the leg, less blood flow, it's going to go to that extremity. So no elevation, keep your leg dependent. Your dressings will be dry dressings. You want to manage the pain. You want to do a high protein, calorie, and vitamin diet. Treat any infections with antibiotics. In worst case scenario, they might need surgery and you have to amputate. So on the other hand, let's talk about venous insufficiencies. So this issue happens whenever we have valves that have trouble returning the blood back to the heart from the legs because an incompetent valve or issues with basically the flow. Causes that can lead to venous insufficiency are blood clots, varicose veins, or just unknown. Risk factors is women, age, family history, a history of a clot, obesity, pregnancy, and being tall or sitting or standing for prolonged time. Check out the manifestations of how it manifests compared to PAD. So here we have edema, the legs swell up big time, especially when they stand. Pain increases when they're standing because everything kind of pulls into that extremity. They have this dry, cracky, flaky, and leather looking skin that gets thick And also this brownish pigmentation, especially in the lower part of the leg, kind of ankle area. And sometimes it develops into having venous ulcers, which are not your typical pretty border ulcer. They're very raggedy and just very deep and kind of ugly looking. But I'll show you a picture here in a minute. How do we treat it? Well, we do compression bandage for these patients and do moist dressings. Moisture allows for wound healing and kind of heal that tissue back on the bed of the wound. High nutrition, high protein, calorie, vitamins, same thing. You want to culture the wounds to see what's basically growing and treat it accordingly to the antibiotic that kind of kills that bacteria through a culture and sensitivity. Sometimes these wounds need to be debrided. So debridement and grafts needs to be inserted. And so that's up to the physician and how bad the wound is. For the edema, we encourage the patients to elevate their legs to decrease the inflammation and treat pain with medications, especially before dressings. We educate them to replace their stockings every 4 to 6 months and avoid long periods of standing or sitting. Here's how the venous ulcers look. If you notice, you know, the borders are not really distinct. They're all over the place. And also they can be very deep where you can see tendons and sometimes muscle and bone. Here's that easy to read or kind of hint on how to remember arteriovenous versus venous. And again, you know, I'm going to skip through these, but you can pause me if you want to look at the details. All right, let's talk about varicose veins. So varicose veins are these swollen and dilated, twisted veins that pretty much is a result of weakening of the vein wall, and they have incompetent valves as well. So everything starts pulling and they get so swollen sometimes that you can visibly see them on patients. The risk factors are women, Hispanic, over the age, pregnancy, obesity, poor posture, prolonged standing position, and constricted clothing. They manifest by having this achy, heavy feeling of the leg, also pressure and cramp sensation, like cramps. Sometimes it's just easy to see them on the individual, and as well as pain. You diagnose them with just a physical examination on the client, and we treated by conservative and supportive treatment, just rest, limb elevation, compression stockings, straightening exercises, weight loss, since weight loss is a risk factor, or weight gain, I mean obesity. There is a procedure called sclerotherapy that basically it's minimally invasive, where they treat the varicose veins or spider veins by injecting this hypertonic solution into the actual vein, and that causes the vein to kind of collapse and shrink, and it disappears and destroys it. Now, after the procedure, they should be taught to have compression stockings per recommendations of the physician, and avoid traveling long distance for about a week. And it almost looks like this. Very little needle, and it just whoop, it collapses. A lot of people that have spider veins get this. Okay, let's talk about phlebitis. Phlebitis is an acute inflammation of the wall of an IV vein that's been inserted either in the hand or the wrist, and it just looks just like that. It kind of, you can see it, you can palpate it, and so they manifest by being pain, tenderness, warmth, redness, swelling in this palpable cord, just like the picture. We treat it usually by just removing the catheter as fast as we can. If it's swollen, let's go ahead and elevate the extremity or the leg, or sorry, not the leg, the hand or arm, and then apply warmth, like moist heat, and then give something for pain, such an anti-inflammatory, something easy like ibuprofen. The risk factors to develop phlebitis are anybody that has irritation to the catheter or has a catheter, infusion of very irritant drugs. And when I talk about a catheter, let me clarify this. These are small catheters, like small veins. This typically doesn't happen on a central line, so to speak, because those are large veins. And then another risk factor is the location, the placement, areas with flexion. That's why we try to always avoid the AC or the wrist because they flex. Okay, the next topic is venous thrombosis or deep vein thrombosis. We call it DVT as well. This is the formation of a thrombus or clot with inflammation of the vein. And there's this Workshop triad that kind of leads to blood clots. There's endothelial injury, then you have this coagulation that happens, and then it kind of affects the blood flow, and that leads to a thrombus. So who's at risk? Well, anybody that really has decreased mobility, whether it is because of a surgery, because you have an issue walking, you're bedridden, you have a, let's say, age that inhibits someone from moving as often, or long trips, stroke. We can also have people people that are at risk that have had surgery, especially abdominal, thoracic, and orthopedics. Individuals with hormone therapy, like oral contraceptives, like women, and bleeding disorders. Some individuals with AFib, and you're going to learn soon, or in my lecture, or
TCC Police Dispatch Center,
or my lecture of dysrhythmias, that whenever the heart is quivering, those atriums, the blood can pool there. People with dehydration and malnutrition, smoking, or a catheter. Now, we do have superficial vein thrombosis and deep vein thrombosis. The superficial, just like this picture, you can see it on the skin, has this tenderness, itching, redness, warmth, and induration along the vein. Usually feels like a palpable, firm, core-like vein, and has edema rare, okay? They could swell a little bit, but not too much. Now, on the other hand, on deep vein thrombosis, they do have swelling, usually sensitive to pressure. They have a sense of fullness. It can happen more often in the lower legs. So usually you see one leg kind of bigger than the other, and it's unilateral. There is something called the Hoffman sign test, and basically they do dorsiflexion of the leg, and if the person experiences pain, it's like a positive for a DVT. However, this is not reliable. And usually what leads for them to get a diagnostic is a ultrasound, because it's easy. They could take it to the bedside and, diagnose someone fairly quickly and less expensive. Now they can get a CT and an MRI, but these are for, bigger cases. Another thing that the physician could order are blood studies such as hemoglobin hematocrit, and this tells us how many red blood cells or if the patient is dehydrated, and your coagulation studies, your platelets, ACT, activated clotting time, your APTT, activated partial thromboplastin, and your INR, your international normalized ratio. These are all in page 816 and 818. I really encourage you to look at what's standard and what's therapeutic and memorize those numbers, because you're going to need them for the rest of your career, for NCLEX, the exam, and everything. Okay, and how do we treat deep vein thrombosis? Is prevention and prophylactic. So that is why in the hospital, we all have our patients either on SCDs or TED hoses. We ambulate them often. We want them out of the bed. We want them in the chair. We turn them every 2 hours, or we give them an anticoagulant therapy, and they have it scheduled in their MAR. I'm going to talk in another video about the anticoagulant therapy. So just if you're looking for just that, you'll see it in a different video. Some individuals, if they cannot get anticoagulant therapy for X or Y reason, and they're higher risk, they get something inserted in them in the vena cava, inferior vena cava, and it's a filter, and it looks like this. And pretty much what happens with this filter is that it's trying to catch any clots that might develop from the lower extremities, and it doesn't prevent them from flowing to their lungs or heart or their brain. And so this is very helpful to prevent it. Okay, well, I hope this review was helpful. And for the next video, I will be talking about the anticoagulant therapy. I'll see you in the next video. Bye-bye.